ರೆಕಾರ್ಡಿಂಗ್ ಎಲ್ಲ ಆಗ್ತಾ ಇದೆ. ಆಮೇಲೆ ನಾನು ಬರೀ ಏನು ಮಾಡೋದು ಅಷ್ಟೇ. ಕ್ಲಾಸ್ ಎಂದಾದ್ಮೇಲೆ Good morning, everyone. And today's my topic for the class will be Evanthematous illnesses. So before starting that, let's find out what is this terminology means. What is exanthema? It means the eruption of the skin. If it is enanthema means there is eruption of mucosa. What do you mean by macule? It is a flat, non-palpable lesion. Papule means it's a small palpable lesion. Nodule is large palpable lesion. Whereas vesicle means it's a small fluid-filled lesion. Pullae means it's a large fluid-filled lesion. What do you mean by pleomorphism? It's a presence of lesions in a different stages of development at the same time. Okay, this is usually seen in chickenpox. With this few introduction, let's go over the today's topic, exanthematous lesions. So means there is an eruption of skin and or skin lesions. Today we'll be discussing with the two topics. One is the mumps and another is varicella chickenpox. So let's start over with mumps. What do you mean by mumps? It's an acute self-limited condition. It's an unusual in the developed country. As we all know, we have started with a widespread use of vaccination. So what are these characteristic features? It has got fever, bilateral or unilateral parotid swelling, and also there is a tenderness in the parotid gland, and there's a frequent occurrence of these complications such as meningoencephalitis and also orchitis. So what is the etiology? The etiology is mumps virus, which belongs to a family Paramyxoviridae and the genus Rubiola virus. Okay, what a type of virus it is? It is a single-stranded pleomorphic RNA virus, and it is encapsulated in a lipoprotein envelope and possessing 7 structural proteins. So which surface glycoproteins? There is a surface glycoprotein called HN, that is hemagglutinin and neuraminidase, and F for fusion, which mainly mediate absorption of the virus to host cells and penetration of virus into the cells respectively. So what does these two proteins will do? They will stimulate the production of protective antibodies. And mumps virus usually exists in single immunotype, and in the humans are only the natural host. So that is why it is easy to do the vaccination having a single immunotype, and human is only the natural host. So what will be the epidemiology? In the pre-vaccine era, what used to happen is mumps is usually seen in young age children between the ages of 5 and 9 years, and epidemics are about once in every 4 years used to happen. So mumps infection occurred more often during the winter and also on the spring months. The incidence of mumps actually fell very dramatically in young children, and it is mainly instead it has becoming more common in the older children, adolescents, and also young adults. So let's see what may be the reason. So outbreaks used to continue even in the highly vaccinated populations as a result of vaccine failure, and also because of under vaccination of susceptible children. So with the the epidemics and all those things, they started implementing 2 doses of measles, mumps, rubella vaccine, and it has started in 1989. And there followed by that, there will be a decline in the number of mumps cases. Whereas in 2001 to 2003, we have noticed that less than 300 mumps is reported in each year. By 2006, there's the largest mumps epidemic seen in the 20 year and occurred in the United States. Mumps is usually spread from one person to another person by respiratory droplets. The virus, it mainly appears in the saliva from up to 7 days before as long as 7 days after the onset of parotid swelling. The period of maximum infectiousness is seen 1 to 2 days before and also 5 days after the onset of parotid swelling. Therefore, viral shedding is happening before the onset of symptoms, and in the asymptomatic infected individual impairs the efforts to contain the infection in susceptible populations. Therefore, in the United States, there is a place called Center for Disease Prevention, and also the American Academy of Pediatrics and the Health Infection Control Practices Advisory Committee recommended there should be an isolation of 5 days after the onset of parotitis for patients with mumps, both in community and also in the healthcare settings. What is the pathogenesis in this? Mumps virus, which mainly target the salivary glands. That is why we repeatedly saying that parotid gland, parotid gland, parotid gland. So it is mainly targeting the parotid salivary glands and the central nervous system, pancreas, testes, and to lesser extent the other places like thyroid, ovaries, heart, kidneys, liver, and also the joint in the synovium. So following the infection, there will be an initial viral replication and occurs mainly in the upper respiratory tract. And the infection usually spread to adjacent lymph nodes by lymphatic drainage, and also the viremia sets in and spreading the virus to above mentioned targeted tissues. It causes mumps virus, it causes the necrosis of infected cells, and it is associated with lymphocytic inflammatory infiltrate. The salivary glands, what happens? It is mainly lined with the necrotic epithelium and also the interstitium, which is infiltrated with lymphocytes. And in the testis, there is the swelling of the tissues, which result in the focal ischemic infarcts. Whereas when we do the lumbar puncture, the cerebrospinal fluid, which mainly shows mononuclear fluocytosis, even in an individual without have the specific clinical signs and symptoms of meningitis. What about the clinical manifestation? The incubation period of mumps ranges from 12 to 25 days, but it is usually the disease duration will be 16 to 18 days. The infection may result in a clinical manifestation which is resulting in asymptomatic or non-specific symptoms to a typical illness, as we already saw, parotitis, which is one of the salivary gland, with or without a complication involving the other organs. Typically, the patient is mainly present with prodrome phase, which is lasting for about 1 to 2 days, and it mainly consists of fever, headache, vomiting, and achiness. First, the parotitis appears, may be unilateral initially, but later on it will become bilateral. The parotid gland is tender, and parotitis may be preceded, and it is accompanied by ear pain. It may be initially the ear pain, or it may be accompanied by ear pain on the ipsilateral side. On ingestion, it may be a sore or acidic foods or liquids may enhances the pain in the parotid area. As swelling progresses, the angle of the jaw may be obscured and earlobe may be uplifted and also outward. Here is the schematic presentation of parotid gland, which is mainly infected with the mumps, and it is mainly compared the picture on the right side with the left side. Right side is the normal gland and the left side is, yeah, the right is the normal, sorry, left is the normal and the right will be the infected with the mumps. There is an imaginary line which is mainly bisecting the long axis of the ear, which mainly divides the parotid gland into two equal parts. But even after the enlargement also, the anatomical relationship is not affected, not altered. And there may be an enlarged cervical lymph nodes are usually seen in the posterior to the imaginary line. The only thing here to know is that even after there is an enlargement, there is the anatomy is maintained. So here is the mumps of the child with a mump showing the parotid gland swelling. So what happens is there is an opening in the parotid gland which is called Stenson duct, which may be a red and also the edematous. The parotid swelling, which mainly pricks approximately in 3 days and gradually subsides over 7 days. The fever and other systemic symptoms, which usually resolves in 3 to 5 days. There may be, very rarely we see morbilliform rash. The other salivary glands which are affected will be submandibular, but most common one will be the parotid gland. There may be an edema over the sternum as a result of lymphatic obstruction. How should we make the diagnosis? When mumps are highly prevalent, the diagnosis is mainly based on the history of exposure to mumps infection and with the history of appropriate incubation period and development of typical clinical findings. The confirmation and there is a presence of parotitis may be made by the demonstration of elevated serum amylase because it's in a salivary gland. There may be an leukopenia with relative lymphocytosis, which is a common finding because it's in a viral infection. In patient with parotitis, which is lasting longer than 2 days and of unknown case, a specific diagnosis of mump should be confirmed and ruled out by virologic or serological means. This step may be accompanied by isolation of the virus in cell culture, detection of viral antigen by direct immunofluorescence technique, or identification of nucleic acid by reverse transcriptase polymer, that is RT-PCR. The viruses can also be isolated from upper respiratory tract secretions, CSF or urine during the acute illness. Serological testing is usually a more convenient and available mode for diagnosis. Serum mumps IgG antibody between the acute and convalescent serum specimens as detected by complement fixation, neutralization, heme agglutination or enzyme immunoassay test to mainly to establish the diagnosis. What are the differential diagnosis? The parotid swelling, which is mainly caused by infectious and also the non-infectious etiology. Means when the parotid is present, it is not necessarily because of mumps infection. It can be because of other viral illnesses also. So those include, it may be para-influenza 1, para-influenza 3 illness viruses, influenza A, cytomegalovirus, Epstein-Barr virus, enterovirus, lymphocytic choriomeningitis virus, and also HIV. The purulent perioditis can be means bacterial infections which is mainly caused by Staphylococcus aureus, which is unilateral and it is extremely tender and it is associated with elevated WBC count. The non-infectious causes of parotid swelling, which mainly include there may be an obstruction of Stenson's duct, or it can be because of collagen vascular diseases such as Sjagren syndrome or SLE or even the tumor. So we said infectious and non-infectious. Infectious we told viral infections and also the bacterial infections. Non-infectious is already mentioned. What are the complications? The most common complication of mumps are meningitis with or without encephalitis and gonadal involvement. That is, we said already, orchitis. Uncommon infections, complications include conjunctivitis, optic neuritis, pneumonia, nephritis, pancreatitis, and also thrombocytopenia. Maternal infection with the mumps during the first trimester of pregnancy may result in the abortion. No fetal malformations have been associated with intrauterine mumps infection. Means it will not cause congenital malformations. Perinatal mumps diseases has been reported in infants born to mothers who acquired the mumps late in the gestation. What about the treatment? As such, as we know, it's a viral disease as such, and we already said it's in a self-limited in the beginning itself. There is no specific antiviral therapy. The management should be aimed at reducing the pain, which is mainly associated with meningitis or orchitis, and maintaining the adequate hydration. The fever can be reduced by using the antipyretics. Prognosis, the outcome of mumps it's always excellent, but the diseases can be complicated by the encephalitis. Although the fatal cases from the CNS involvement and also myocarditis have been reported. What about the prevention? As we said, it's a single immunotype, and also there is a human is the only natural host. So it can be prevented by live mumps vaccination, which is the primary mode of prevention. It is given as a part of MMR, that is measles, mumps and rubella, and 2 doses at 12 to 15 months of age for the first dose and 4 to 6 years of age at the second dose. If not given at 4 to 6 years, the second dose can be given before the children enter the puberty. Regarding this vaccination, it changes as we study more and more about the diseases. In nowadays, they say that even with the measles vaccination at the 9 months, it can be given, and the second dose can be given around 15 months, and no need to give around 4 to 6 years. So it is getting updated as we know more and more about the diseases. The median vaccine effectiveness of mumps after the first dose of vaccine is 78%. If the child has received 2 doses, then it is 88%. The duration of effectiveness, it is more than 10 years after the first dose and more than 15 years after the 2 doses. The adverse reactions are very unlikely with mumps vaccination. So since we are finished with our mumps, this one viral illness, the next virus will be Varicella zoster. The Varicella zoster viruses, which mainly causes primary, latent and recurrent infections. The primary infection, which is mainly manifested as varicella, that is chickenpox, and it results in the establishment of lifelong latent infection, mainly in the dorsal root ganglion. Reactivation of the latent infection, which mainly causes herpes zoster, which is also called shingles. It's a neurotropic human herpes virus with the similarities of herpes simplex virus. Neurotropic means more affection towards the nerves. These enveloped viruses, which mainly contains double-stranded DNA genomes that mainly encode more than 70 proteins, including the proteins that are the targets of cellular and also the humoral immunity, means T cell and B cell immunity. Varicella, it's a very serious disease in case of young infants, adults, and also in the immunocompromised persons, in whom there are higher rates of complications, deaths than in healthy children. Within the households, transmission of varicella zoster to susceptible individuals can occur at the rate of 65 to 86%. So you should be careful. Persons with the varicella are contagious 1 to 2 days before the rash is evident and until the vesicles are crusted, and usually 3 to 7 days after the onset of rash. Susceptible persons may also acquire varicella after the close contact, direct contact with the adults or children who have an herpes zoster. What about the pathogenesis? It is mainly transmitted by contact with oropharyngeal secretions and the fluid of the skin lesions of infected individuals, either airborne spread or through the direct contact. The primary infections, that is varicella, which mainly results from inoculation of the viruses onto the mucosa of the upper respiratory tract and also tonsillar lymphoid tissue. During the early part of 10 to 21 day incubation period, virus mainly replicates in the local lymphoid tissue. Then a brief subclinical viremia spreads the virus to the reticuloendothelial system. The widespread cutaneous lesions occur during the second viremic phase that mainly lasts for about 3 to 7 days. In the peripheral blood, mononuclear cells will carry infectious viruses, generating new crops of vesicles during this period of viremia. It is mainly transported back to the mucosa of upper respiratory tract and oropharynx during the late incubation period, permitting the spread of susceptible contacts 1 to 2 days before the appearance of rash. The clinical manifestation, varicella, is an acute febrile rash illness that is common in the children before the universal childhood vaccination program. So it is associated with several severe complications, including staphylococcal and streptococcal superinfections. And also it will lead to pneumonia, encephalitis, bleeding disorders, congenital infection, and also life-threatening perinatal infections. About this, we are going to see in following slide. Illness usually begins 14 to 16 days after the exposure, although the incubation period can range from 10 to 21 days. Almost all the exposed children will experience a rash. It can be a severe rash or it can even be a mild rash. Prodromal symptoms may be present particularly in the older children and also the adults. Fever, malaise, anorexia, headache, and occasionally mild abdominal pain may occur 1 to 2 days before the appearance of rashes. Temperature can be 100 to 102 degree Fahrenheit. It can go as high as 106 degree Fahrenheit. Fever and other systemic symptoms usually resolve 2 to 4 days after the onset of rash. What about the rash? Where does it appear? It appears on the scalp, face, and trunk. The initial examination of the initial exanthema, which mainly consists of intensely pruritic erythematous macules that evolve through the papilla stage to form a clear and fluid-filled vesicles. So macule, papule, vesicles can be seen. That is pleomorphic rashes. Clouding and umbilication of the lesions begin in 1 to 2 days. While the initial lesions are crusting, new crops form on the trunk and then on the extremities. The simultaneous presence of lesions in various stages of evaluation, which is characteristic of varicella, that is pleomorphic. The distribution of the rash is predominantly centripetal. What do you mean that? It is towards predominantly to central, with the greatest concentration on the trunk and proximally on the extremities. The ulcerative lesions are usually seen on the mucosa of the oropharynx and also vagina. The average number of varicella lesions is about 300, but healthy children may have less than 10 to more than 1500 lesions. These in cases resulting from secondary household spread and in the older children, more lesions usually occur and new crops of lesions may continue to develop for more than 7 days. Breakthrough varicella. What is this? It mainly occurs in a person which is vaccinated already, who is been vaccinated for more than 42 days before the rash onset, and is usually caused by wild type virus. One dose of varicella, it is more than 97% effective in preventing moderate and severe varicella, and 85% in preventing all the diseases after the exposure to wild type varicella zoster. This means that the exposure to varicella zoster is as may occur in household or in outbreak setting in a school or a daycare center are less contagious. About 1 in 5 children who has received one dose of varicella may experience breakthrough varicella. The rash in breakthrough varicella disease is frequently atypical and predominantly maculopapular vesicles are less commonly seen. The illness is most commonly with less than 50 lesions of more than shorter duration of rash and also fever complication and little or no fever. What about neonatal varicella? The infants whose mothers demonstrate varicella in the period from 5 days prior to delivery or 2 days afterward are at higher risk for varicella. These infants will acquire the infection transplacentally as a result of maternal viremia and may occur up to 48 hours prior to the onset of maternal rash. The infant's rash usually occurs towards the end of the first week or to the early part of the second week of life, but it can occur as early as within 2 days. What about congenital varicella syndrome? It approximately happens in 0.4%, means 4 out of 100 babies born to women who have varicella during pregnancy before 13 weeks of gestation and approximately 2% of infants born to women with varicella between 13 to 20 weeks of gestation. Let's see the complications. The complications are more commonly seen in immunocompromised patients. In healthy child, mild varicella hepatitis is relatively common. Mild thrombocytopenia can be seen in 1 to 2%, which is associated with transient fatigue, purpura, hemorrhage, vesicles, hematuria, GI bleeding. These are the rare complications we are going to see. Other complications may include CNS such as acute cerebellar ataxia, encephalitis, pneumonia, nephritis, nephrotic syndrome, hemolytic uremic syndrome, arthritis, myocarditis, pancreatitis, orchitis, acute retinal necrosis. How should we make the diagnosis? It is primarily by the clinical appearance. Means on exam, seeing the vesicles, this one macular rashes, papular rashes, all those things. Maculopapular rashes, scab formation, and with the history of fever, onset of the fever, followed by development of the rash, and the way the rashes has been distributed. All those things helps with the clinical examination and also with the appearance we are going to make. Laboratory evaluation has not been considered for the necessary further diagnosis or management. Atypical nature of breakthrough varicella with higher proportion of papillar rather than vesicular and poses both clinical and laboratorically diagnostic challenges. Leukopenia, which is usually seen 72 hours after the onset of rash and followed by relative or absolute lymphocytosis. The liver enzymes may be elevated and liver function test may be altered, and patients with neurological complications of varicella may have mild lymphocytic phagocytosis and a slight to moderate increase in protein content of the CSF, but the glucose concentration is usually normal. How should we confirm? It is accomplished by referral hospital laboratories and all the state health laboratories, which is quickly by direct fluorescent assay of the cells from cutaneous lesion, that is from the vesicular fluid, in 15 to 20 minutes, or by RT-PCR, that is PCR amplification testing of vesicular fluid crust, vesicular fluid or the crust, and in hours to days depending on the availability, and by the rapid culture with a specific immunofluorescence staining, that is by shell vial technique in 48 to 72 hours. So coming to the treatment part, it's an antiviral treatment which mainly modifies both the varicella as well as the herpes zoster. The antiviral drug resistance, which is usually rare and primarily seen in children with HIV infection and other immunocompromising conditions, where the frequent relapses of varicella infections has resulted in multiple courses of antiviral therapy. What are the drugs? Forscarnat or cidofovir, which is useful in the treatment of acyclovir-resistant varicella infections. But consultation of infectious specialist, which is also recommended. The only antiviral drug in the liquid formulation that is licensed for the treatment of varicella for pediatric use is acyclovir. So how should we give? It's 20 mg per kg per dose or maximum of 800 mg per dose. Given in 4 doses per day for about 5 days and can be used in the treatment of uncomplicated varicella in an individual which are at increased risk for moderate to severe varicella. To be more effective, the treatment should be started and should be as early as possible, preferably within 24 hours after the onset of fever. The less clinical benefit if the treatment is initiated after the 72 hours after the onset of exanthema. The intravenous therapy is also recommended for the severe disease and for the varicella in immunocompromised patients, even if they begin more than 72 hours after the onset of rash. The treatment in these people will be continued for 7 to 10 days or until no new lesion have appeared for next 48 hours. In the case of acyclovir-resistant varicella zoster has been identified primarily in children infected with HIV. These children may be treated with intravenous forscarnat, which is 120 mg per kg per day, with every 8 hours for up to 3 weeks. So what about the prognosis? Primary varicella has a mortality rate for 2 to 3 per 100,000 cases, and it has got the lowest case mortality rates among the children of 1 to 9 years of age. The infants have a 4 times greater risk of dying, and adults have 25 times greater risk of dying. Means adults are more have a bad prognosis compared to the children. The most common complication, which is mainly died because of varicella, or if they had history of pneumonia and also central nervous system complications, secondary infections, and also the hemorrhagic conditions. If left untreated, the primary infection, the mortality will be 70 to 14% in immunocompromised children and 50% in untreated adults with pneumonia. So the prevention, varicella zoster transmission is difficult to prevent because the persons with varicella is contagious for 24 to 48 hours before the rash is apparent. So what about the control? The practice is to suggest caring for the infants with varicella is isolation rooms with filtered air system is most important. Unvaccinated healthcare workers without other evidence of immunity who have had exposure to varicella zoster should forego for days of 18 to 21 after the exposure because of their potentially infectious during this period. So again, the varicella, it's an vaccinal preventable disease. It contains live attenuated Ocosa strain. It's a subcutaneous administration. The route of administration is a two regimen, which is mainly seen in healthy children at the age of 12 to 15 years and also at the 4 to 16 years. The minimal interval between the two doses is 3 months apart or 12 years of age or younger, 2 doses with 3 months apart if it is 12 years of age, and 4 weeks for the older children and adolescents and also the adults. Usually it is given as a MMR vaccination, which is higher risk for breakthrough disease, and it is recommended that varicella and MMR vaccine should be either be administered simultaneously or at the different side of at least a given at 4 weeks apart. So it is administered as a monovalent or it can be a quadrivalent measles, mumps, rubella, varicella vaccine for children of 12 to 24, 2 to 12 months to 12 years of age. What are the adverse events? It's a safe, well-tolerated, local complications can be observed. The incidence of injection site, the complications are observed 3 days after the vaccination and it is slightly higher dose of the 2 doses than after the first dose. The mild vaccine-associated varicella form rash has been reported in approximately 1 to 5% of healthy vaccines, consisting of 6 to 10 papillary lesions and healthy the papillovesicular lesion. The mild vaccines are usually associated with varicella form rash, and it is reported approximately in 1 to 5% of healthy vaccinees, consisting of 6 to 10 papillary vesicular erythematous lesions with a peak occurrence of 18 to 21 days after the vaccination. What about post-exposure? So it is given mainly to healthy children within 3 to 5 days after the exposure. As soon as possible, it should be preferred, and it is effective in preventing and modifying the varicella. Vaccine is now recommended for post-exposure use and outbreak control. Oral acyclovir is mainly administered late in the incubation period and may modify the subsequent varicella in the healthy children. However, its use in this manner is not recommended until it can be further evaluated. The high titers of anti-varicella immunoglobulin as a post-exposure prophylaxis is mainly recommended for immunocompromised children, pregnant women, newborns exposed to varicella. The recommended dose in one vial is 125 units for 10 kg for a 10 kg increment of body weight, and maximum of 625 units, except for the infants weighing less than 2 kg, it should be a 0.5 vial. Varicella immunoglobulin should be given intramuscularly as soon as possible and may be efficacious for 10 days after the exposure. We already said there is a transplacental transmission. So the newborns whose mothers demonstrate the varicella 5 days before or 2 days after the delivery, they should receive varicella immunoglobulin, that is 0.5 vial for those weighing less than 2 kg and one vial for those weighing more than 2 kgs. Thank you. Okay, the questions may exit ಆಗ್ಬಿಟ್ಟಿದ್ದೀರಾ? Okay, the questions may appear in the case of mumps and also in the case of varicella. So the questions will be continue. The questions will be one in the you have the vaccination table. There they may ask about the MMR vaccination. So you need to know about how the vaccines are given and how to dilute and what is the route of administration. And there may be in a question in the short note saying the chicken pox or the measles. So there they may ask like congenital varicella or other questions may be asked. So it is most and the more important than that is it is the common disease which is seen in OPD basis. Means a lot of children coming with there is a swelling in the one side of the cheek, or there may be a swelling in both the side of cheek, or it may be they said like there may be a rashes and all those things. So it is important to diagnose this disease, and it is more commonly seen on OPD basis. ಒಂದು ನಿಮಿಷ ಇದು ಮಾಡಬೇಕಲ್ಲ, ಅಟೆಂಡೆನ್ಸ್ ಮಾಡಬೇಕು. ಅದ್ರಲ್ಲಿ ಓಪನ್ ಮಾಡಿ ಹೇಳ್ತೀನಿ. ಸ್ಟಾಪ್ ರೆಕಾರ್ಡಿಂಗ್ ಮಾಡಬೇಕು.